Amazing, thank you. Good afternoon, everyone. It's a pleasure to be speaking about COVID-19, the pandemonium, and the challenges and BSMS's responses. I'm doing this today with myself, Professor Claire Smith. I'm Head of Anatomy, our Deputy Head of Anatomy, Aidan Jayanth. Also, this talk contains material previously prepared by Dania Stone, contributions from Tim from our TEL team, and there's also material in this talk from our anatomy demonstrators. When thinking about the title, I had a look back through the past couple of years of all the material that was on the BSMS's news stories, and I was just amazed. I could not fit them all on this screen. There were many more news stories, and actually picking out BSMS's response to the pandemic was an absolute delight, and actually quite a kind of looking back over time, you just don't realize actually how much we've achieved in that time, and it's testament to everyone as part of the team. If you want to read anything more, these are all still archived on the BSMS web pages. Using some very overarching thematic analysis, I think we can categorise BSMS's response under 4 headings: that of community, widening access, digital learning, and the science. As with other medical schools, BSMS had to quickly enable its Year 5 students to undergo OSCEs and to get them directly into the workforce. And this was obviously a large undertaking by the OSCEs teams, the assessment teams, and everyone else involved. At the same time, our clinical skills teams were pulled into the NHS to provide essential training to those that were returning to practice, and also in infection control and prevention. The medical school, through its research facilities and anatomy, were also supporting the local community with PPE needs. And within anatomy, something I'd never ever thought I'd be asked to do, we were approached by the local council, and we ended up providing a temporary mortuary in the university car park, which eventually, under the second wave, we cared for over 400 deceased individuals. And I guess that's really, testament to skills of staff, that actually there's so much transferable skills, familiarity with human tissue authority. It might not have been in our area, but we were quickly able to apply it. At the same time, our medical students were supporting the university, helping with COVID testing. As you can see, you can't see, I was going to say, you can't see their smiley faces, but you can see their faces just down here, there. Many of our other medical students were also involved in supporting the NHS work in a wide range of roles, including providing childcare for staff in the early phase of that. Members of the BSMS community were also campaigning for the use of clear masks to help with individuals who require lip reading and rely on key facial clues for understanding. The BSMS communications team was maybe the first of some of the medical schools to undergo online graduation, and that was a fantastic event, as you can see here. Not quite the same as usual, but it was fantastic. Also, we were aware of supporting all of the BSMS staff and community, and we did that through a number of ways, including our staff wellbeing pages, which you can see down here, having weekly quizzes, support cafes, online cafes, and supporting the team. The widening access team did outstanding and award-winning work of creating virtual work experiences for prospective medical students during that time, and that's been recognised by national awards. On the digital learning side, you're going to hear more about this as part of this presentation. The TEL team, as with all TEL teams across the world, were kept incredibly busy by delivering, helping us move to a new mode of delivery. the science of things, BSMS researchers were helping to use mathematical modelling to work out local outbreaks, and also looking at the use of blood thinners to support COVID patients. For the rest of this presentation, we'd like to focus more on the medical student experience and journey, and we'd like to do that looking particularly at digital learning and teaching. Before I hand over to my colleague Tim, I think it's important to acknowledge the amazing support that the TEL team gave to everyone, and probably never got a lunch break in 2 years. We're incredibly busy and helped us all. And so, Tim, if I could hand over to you now to talk through some of the other aspects briefly.
Absolutely, yeah, happy to do that. I'll ask you, Claire, just to move on the slide at the necessary point. There's not a lot on there. Okay, hi. So I'm Tim Vincent. I'm one of a team of 3 who support the teaching staff in our postgraduate and undergraduate taught courses, and it is our role to support our educators, be those they on the academic side, the university base, those who have module and sort of intense program part of their contract, but also practice healthcare, and those many of whom are far beyond that and do a lot of our teaching out there in the real world. So just to cover some of the elements here, we have Capsules, one of our clinical cases app. It was a unique resource that we had available to us. Well, started in 2007, but in 2016 it was made into a modern learning resource, which was delivered on a high quality platform to students. So there's an element of talking around that. I'll just go into a bit more detail about the impact of going outside just BSMS in the COVID world. We had an existing Anatomy Lab interface app, and this is actually a secure, bespoke, web-based platform designed specifically for tablet devices to be used in the dissecting room. But actually, those resources were actually available to students who could no longer come into the lab. So that was a real lifesaver, as it were, for having those resources already bundled into a secure platform to make sure that they conform to the Human Tissue Act, and to making sure that they are secure and students can't abuse any media or resources there. And so that was also available to our students. And then, sticking with the anatomy theme, we had a whole range of other resources. We launched into the world of live streaming using cameras. So Professor Smith being able to undertake, and colleagues being able to undertake dissections with that live streaming out to a variety of audience. So we had not just our students, but also being able to make it available to audiences, appropriate audiences outside that. We already had a whole library of dissection videos previously created, these running in line with the taught program, again behind a sort of secure area for our students. So being able to direct students to those, absolutely vital. And then exciting work around that world of virtual reality and using 360 videos, being able and images, being able to expand that out, and we're going to hear a bit more about that later. So Claire, if you want to move it on to the next slide, please. Thank you. So just a word about Capsule. This is a commercial partner that we're working with, Acasta, the development studio in Brighton. And based on student feedback, Capsule was designed as a formative assessment tool. It is a clinical case-based mobile app and website. built on contemporary current technologies, so it looks and feels fantastic, and that was developed again very much in partnership with students. And you can see here I've got the magnifying glass for the process for students working through investigation, then diagnosis, and then management of clinical cases. And these are essentially mapped across the entire curriculum, ultimately aimed at the finals level, but covers all the specialties. We provide for our students from year 3 to 5, so the slightly more clinical elements where they go into hospital. And there's currently over 700 cases, that's 3,500 questions. The important element is that they all have feedback written by, and the content is all written by clinical academics, people who are connected with the school, and is overseen by an editorial boards. And that's very important because we want to ensure that it is at the appropriate level. Plus there's detailed feedback, but this is a learning exercise. And the important element as well is, unlike commercial revision-based apps, is that we as the school and the institution has ownership and sight of the data. So you can actually use it as part of the teaching program. You can see how students are using it and how they're performing. So that was in place in 2016. We were beginning to make it available to other students, but come lockdown, and all of a sudden we no more clinical placements, the great crisis there. So through the sponsorship of the Medical Schools Council and their generous sponsorship there, and with significant help from Imperial, Claire, if you press the button a few times, there may be some other elements. Yes, there we go. So Capsule went national in terms of, within a few weeks, we had to check the quality again of all the content. That is a colossal effort by a whole variety of clinicians and partners, led largely by us and Imperial College. It was fantastic, and credit to Amir Sam for that, in terms of doing a lot of work in there. So we released that out to some PA courses as well as medical schools. It was made available free to all medical schools in the UK and to the PA courses. And that was a brilliant resource. Feedback was extremely positive, as it was with our students previously. Very useful. And then that was a 1-year sponsorship. I think it actually went out to 18 months essentially, and that was made available. And now Capsule is available as software as a service to schools who wish to subscribe under a good value payment plan, and so we continue that. So at the moment 24 UK medical schools are signed up to Capsule as a resource for their students, plus we've got 6 international partners as well who are looking to have that, and we continue to work as a network across medical education and welcome anybody else to use Capsule as well. So I'll hand over back to you, Claire, to pick up on the next topic.
Thank you. One of the things that we did find at the beginning of the pandemic was not only this move to new ways of working, but also having 2 parent institutions didn't always make it easy when each parent institution chose a different online delivery mode for their students. So we had to adapt, as like all of us did, to that. And we had to find new ways to bring about that sense of community. And that was, created through amazing virtual introductions by Misha and Duncan, but also through slightly humorous things, which if you can bear to hear the anatomy team singing, I thought you might like a little clip of this.
Fine, yeah. It is recording.
So we had to tell our students who we were, what we were, and that actually we were lovely people.
can learn to dissect and have the time of your life. Ooh, find that nerve, mind that spleen, within that between. Friday night ready for the weekend.
Singing clearly.
There's something else we can recommend, where you get the right teaching from a super team. You've got to look for a demo. Everybody wants to be that guy who can find the muscles of the eye. With a bit of revision, everything is fine.
Okay, I'm sure you get the idea, and you can find this on YouTube if you would like to see the rest of it. Great, where's my PowerPoint gone? There we go. So as part of our live brain removal, we had to go through a few steps that we don't do for usual practical classes. We had to seek agreement from the HTA. We had to work very closely with the TEL team and the IT team to make a secure platform. We had to go through actually how we were going to deliver this. So we've got the same learning outcomes, but it was a very different feel to the session and actually what we were going to be able to achieve. We were lucky to actually give it a trial run. And in the end, we're able to deliver live streaming of the brain removal, one of the first classes for our second year students, to over 300 students. And in working out actually how we did this, we had to change our roles as teachers slightly. This is Med, one of our anatomy demonstrators during the pandemic. So we had the specimen in front of us. We had to quickly purchase a 4K camera, so a little bit of funding release for that. We were fortunate to already have the screens in place, but had to work with TEL and IT to get these sessions out using Teams. We had different feeds coming in, but we're also fortunate to have feed coming in through our operating theatre light. And this is the view that students could have seen with us on our smiley faces in the corner. In working out actually from a teaching perspective, what worked, I think you might find these two quotes from anatomy demonstrators really quite telling, that it's slightly harder to get your personality sometimes across, body language, really form those bonds with students when they're online in a setting like we are today. There's less chance for the informal discussion. It was a little bit more tiring, but actually they really relished the opportunity and felt they were really delivering, and they were delivering vital teaching, as well as being working in the NHS the rest of the time, or with our private providers. For students, though, we know that they really missed the hands-on approach to teaching that they get at BSMS, whether that's through some certain clinical skills things, through exploring with ultrasound, through dissection. It felt less personal. I genuinely didn't know hardly any students by name at that point. Some, though, did tell us they enjoyed the convenience of learning online, and maybe it had less impact on lectures than it did in other things. In evaluating students in 2020, we could see that actually we'd done the best we could. Students were giving us favourable feedback, not always amazing to be able to see 3D structures on a 2D screen. But this led us to further thinking and working out. One of the things we've been fortunate to do, which you can play about with on the QR code, is we'd had some 360 GoPros that we'd been using in the lab to create various things, including our website. And we just started playing about with that with the live streaming. At the same time, Jag Danza, one of our maxillofacial surgeons that we work with, was also thinking about live streaming out to surgeons who couldn't get in for training. And this then developed, he's the lead individual for this, into VRIMS, the virtual reality in medicine and surgery platform. And through significant funding from HEE, we've been able to deliver 4 VRIM courses to date, which have gone out to over 1,300 participants. What it doesn't show you there is actually this is across the globe. This is in over 92 countries. So it very much started as a local thing, but very quickly we were aware to work out and through surgical networks to get this training further out. Sometimes this has been through the use of Oculus headsets, and we've been really fortunate to be sponsored by various surgical companies, such as Stryker, you can see here, where the surgical companies have sent out to developing countries such cardboard headsets, or we've provided resources on actually how to make your own cardboard headset. So at set times, this is all live streamed, and surgeons in training can use the 360 headsets to actually be talked through that part of surgery at that point in time. We've now built up a video of hundreds and hundreds of hours, thousands of hours, but also hundreds of videos that can be viewed. And our final aim for this is we're trying to develop it into a Netflix of surgery and anatomy as a resource for much, much wider. Aidan, over to yourself to think about lessons learned.
Thank you, Claire. So I am conscious of time, so I'm just going to run through the last few slides. So I think some of these bits Claire has already spoken to us about, but from a BSMS perspective, I think these are some of the main things that came out from our response to the COVID-19 pandemic. So obviously time constraints, as you can all imagine, overnight we completely shifted from traditional face-to-face teaching to completely online teaching, and preparing resources for them, and not just teaching resources with the information that the students need to know, but also making them as engaging as possible so that the teaching is effective. And I think that's where a lot of issues or a lot of challenges came across. But the other thing which we also realized based on our response to the pandemic is technological issues. I mean, personally for me, I always thought that I was a very technologically literate person, but I think the pandemic just, showed me that I'm clearly not. Things like internet connectivity. So when we're using live streaming, for example, camera quality, camera angles. So those are some of the bits where, and also the different softwares that you use, which was particularly challenging. But I think the most important aspect here, the most important lesson that we learned was about student engagement. Yes, we had very little time to actually, develop a very good sort of an online course or a remote course initially, and then moved on to sort of like a more of a hybrid model or a blended model, if that makes sense. But I think what the most challenging aspect there was to ensure that the students are actually engaged, and to do that purely through an online mechanism was quite challenging. Can we move to the next slide, please, Claire? So going forward, what are we going to do? So it's not going to be, normal as how it used to be, and this is the new normal that we're talking about. So we've learned quite a few lessons. We've used a variety of different methods to teach, not just anatomy, but all of the subjects here at BSMS. So how are we going to use that to adapt to the new normal? What are we going to do? And I think this also relates to, especially when we're going back to the traditional face-to-face teaching, there are students and staff as well who are still apprehensive about the virus itself and about, coming in touch, coming in contact with other people. And I think that is something that we need to consider as well in terms of how we plan in the teaching sessions or delivering teaching itself. And one other thing which would be really important in the future is collaboration between academics from different universities. Because all universities across the UK and all medical schools across the UK, we've used a variety of different techniques to sort of as a response to the COVID-19 pandemic. And I think pooling all of these resources together and sharing best practice will be a really good way forward. I've also highlighted one more point here about interpersonal relationships, really. I think this is one of the things which we found as well when the teaching was fully remote/online, and even in the blended approach as well, as Claire mentioned earlier, it's about maintaining that relationship with your students, but also maintaining relationship with each other. And I think quite a lot of us struggled with that. And because it was a sudden change, it was a bit of a shock, and it took some time to get used to it. So for example, if we were purely just talking about remote learning, and if I'm coming from an anatomy perspective, cadaveric exposure is very important. And there's loads of studies that's highlighted the importance of cadaveric exposure, not just in terms of learning anatomy from a three-dimensional perspective, but also enabling students, particularly medical students, to gain some additional attributes, professional attributes like communication and teamwork, and having that depth empathy. And a lot of the times you refer to the cadaver as your first patient, and I think making anatomy teaching just purely online will actually take away that really important aspect of developing interpersonal relationships. Last slide, Claire, thank you. So what does the future hold, really? And I think the question here would be, do we want to go back to how it was before the pandemic? And if not, then there are a variety of things that we've identified during this pandemic period, which we can use. And I'm not going to bore you with each one of those, because I'm sure you've come across it quite often over the past 2 years. But one of the things which I came across very recently were a high flex mode of learning. So apparently it's a mixture of hybrid and flexible. So it's sort of like an on-demand education where you give students several choices, and they can actually choose what they want to use for each session. So you might have like 100 students, wherein 30 students are learning asynchronously just by watching videos. You might have another 40 students out of the 100 who've come to a face-to-face teaching session, whereas the other 30 students are actually watching it through live via Microsoft Teams or Zoom or things like that. So you're giving students the option to do what they want, but at the end of the day, they all learn and they all achieve the same learning outcomes. Obviously, that's going to increase our workload massively, because you need to provide them different options, but that is one of the future ways of teaching and learning, really. And I think finally to say, we've learned very important lessons, but we've also identified quite a lot of challenges and strengths in terms of what we can do to change the way we teach, so that we are more adaptable, more flexible to respond to things like the COVID-19 pandemic. That's it from me, Claire.
Thank you, Aidan. And that brings us beautifully, you've given us some real food for thought, and into our last slide of any questions. And this is a link by one of the papers about anatomy and COVID, which Daniel within the team was a co-author of. So if you'd like to read more, then please scan the QR code. Back to you, Jim.